Can you hear me?
Yes, sir. We can hear you, Dr. Coselli.
Are we good now?
Yep, we're good to go. All
All
right.
right.
Good morning, everyone. Thank you very much for joining us today for another Aorta Chat interview as part of Aortic Disease Awareness Month. My name is Adam Ahmed. I'm a fourth-year student at CUNY. This morning, we have the privilege of going live with Dr. Joseph S. Coselli. He's professor and executive vice chair of the Michael E. DeBakey Department of Surgery. He's also the Cohen Foundation Endowed Chair and the program director of the prestigious Aortic Surgery Fellowship at the Baylor College of Medicine. Dr. Coselli is internationally recognized for his contributions to cardiovascular and aortic surgery and has held leadership positions in multiple surgical societies, including serving as the 96th president of the American Association for Thoracic Surgery. It's an honor to have him today with us for this interview. Dr. Coselli, thank you for joining us. How are you?
Good morning. Glad to be with you.
Thank you so much. Uh, to start off, we were wondering if you could tell us a little bit about what inspired you to pursue a career in aortic surgery and how your early experiences shaped your path towards becoming an expert in this field.
Oh, very interesting and kind of an unusual pathway. Um, when I was a freshman in college, I spent a summer working as they hired students at the Texas Heart Institute under Dr. Denton Cooley, who I knew through my family as a native Houstonian, both of us. And so I got exposed to the Texas Heart Institute and Dr. Cooley's operating rooms when I was a freshman in college. I was actually headed to law school, and after being in the ORs with them, I switched to going to medical school. And I just loved what I saw. I spent actually 2 summers there. I fell in love with cardiac surgery, and I went to medical school purposely designed to go into cardiac surgery, and I never looked back. At that time, Dr. Cooley was doing a lot of aortic surgery, so that was my first exposure. I then spent 5 years doing a general surgery resident under Michael DeBakey, exposed to more cardiac, vascular, and aortic surgery. I stayed at the thoracic residency with Dr. DeBakey, where I became a cardiac surgeon, but again, more aortic surgery. But when I finished, was really the thing that made the big difference. When I finished my training in cardiovascular and thoracic surgery, I was asked by Dr. E. Stanley Crawford to stay on the faculty of Baylor College of Medicine. And at that time, he was sort of the godfather of thoracoabdominal surgery, but was doing a lot of ascending arch, thoracoabdominal, infrarenal abdominal, you name it. He was an amazing aortic surgeon. I spent 6.5 years working with him as I guess, junior associate, but on the faculty, working directly under him and working with his practice. And when he quit practicing in January of 1991, I took over the majority of that aortic practice and have never looked back.
It's amazing. Okay, thank you so much for taking us through that. You've treated thousands of patients with complex aortic conditions, including completing over 3,000 complex thoracoabdominal aortic aneurysm repairs. Looking back, could you share one particularly memorable patient experience that might have impacted your approach to surgery and patient care?
Well, there's many have done that. I have actually operated on 3,800 plus thoracoabdominal aneurysms and well over 10,000 patients with aortic pathology. Most of it fairly complex because we're a tertiary referral base for these sort of issues, and so that's just what we do. I've had many experiences with many patients that I can just give you two very brief ones, which might serve as examples. There was a young man in Dallas who had Marfan syndrome and an extent three uh, aortic dissection with an extent two thoracoabdominal aortic aneurysm, who was on dobutamine at home because his heart was in such poor function with an ejection fraction of around 20% that he needed a heart transplant. So he came to Houston, and we carried out an extent two thoracoabdominal aortic aneurysm on this gentleman, got him through the operation, which then allowed him to go on and have his heart transplant. He did very, very, very well after that. I had another patient that I probably shouldn't describe in too detailed because you might actually be able to identify him. He's reasonably well known, but he came to us as a young man many years ago with a proximal aortic dissection that extended down into his thoracoabdominal aorta. So that I replaced his ascending and transverse aortic arch, and basically what was the first operation, and then his thoracoabdominal aorta became a problem literally 2 or 3 days later. And fortunately, he was a young man and he was able to tolerate that second operation, which was done just a few days after his first operation. And he was also that was 20 plus years ago, and he's still doing extremely well. And these are the sort of things that drive you to improve, improvise, hone your skills, build your team, and successes like that make all the difference and get you up in the morning.
It's amazing. Speaking of your team, Dr. Coselli, you've helped train several generations of cardio-aortic surgeons. What's your philosophy when it comes to training people interested in aortic surgery? What do you believe are some of the critical skills they should seek to develop early on?
There's in training, there's a lot of aspects of it. It's actually a very, very good question. Training in aortic surgery right now, from most standpoint, requires a lot of open surgery still. So they need to have the basic skills of vascular and well as cardiac surgery if you're going to treat the entire aorta. The ascending and arch aorta are primarily, from an open standpoint, the purview of cardiac surgeons, whereas the remainder of the aorta from the left subclavian artery down is a mixed bag of vascular surgeons as well as cardiac surgeons from an open standpoint. So they need to have the really excellent skills in open surgery and all that entails. The basic training of cardiac vascular surgery in this day and age probably doesn't prepare you to be a dominant situation with regards to aortic surgery. So we recommend that many of these individuals go and spend a fellowship, sort of like what we have, but others have it. Cleveland Clinic, the Mayo Clinic, Penn, New York, etc. Spend an extra year or so in a place where you do a lot of open aortic surgery so you can get that additional experience. The other thing that we like to have our trainees think about, that when the surgery that we do today is quite a bit different than the surgery we did when we trained, because there's been, obviously, and thank God, a lot of advancements over the years. We do things, we think, and hopefully a lot better with. So the people that trained me, for instance, they were doing a lot of cardiac surgery, but when they trained, there was no such thing as cardiopulmonary bypass. So they had to learn to do valve surgery and coronary bypass surgery and cardiac surgery with just the basics of some rudimentary vascular and general thoracic surgery. And so the point is the specialty evolved, and the people that trained us evolved with it, and they were innovators in the specialty. So that I think if you train today, you need to have a mindset that what you may be doing 10, 20, 30 years later might be quite a bit different than what you're actually doing today. And that not only should you have a mindset that your practice is going to evolve and stay up with those changes, but hopefully be one of the innovators and help actually evolve the specialty yourself. When I trained, for instance, and for the first decade or so of my practice, endovascular surgery actually did not exist. I've done over 1,000 endovascular cases, and so I've had to evolve with that aspect of our specialty just in my own career. And I would expect that people training today should, if they really want to be successful, should have that same mindset of evolving and innovating through the years. It's quite likely that a great deal of what we for example, what we used to do in the past, a lot of abdominal aortic aneurysms and descending aneurysms are now done almost, not quite, but almost exclusively with endovascular stent grafts. And we do that. The We've had to evolve with the specialty. So I think they need to have a mindset that they're also going to evolve, train, and hopefully be innovators.
Thank you very much for saying that.
One more last comment on that. It's been a privilege and an honor for me to, as you mentioned, participate in the training of many individuals who practice aortic surgery, and it's quite an honor for me that many of those are actually leaders in our specialty. But I think that the trainees, in addition to evolving and innovating our specialty, also should keep in mind that they too need to become trainers to train their next generation to carry on the specialty that we love.
Absolutely. And for individuals that are starting in the field and keeping in mind these new technologies and innovations that they'll have to contribute to and become familiar with, how would you suggest they balance the introduction of these new innovative methods with perhaps the more time-tested principles of aortic surgery?
You know, it's another good question, and it comes up from time to time. And I'm going to share with you what I suggest. So let's just take an open operation, which is complex. It has a significant physiological impact on any patient who undergoes it, and that would be open thoracoabdominal aortic aneurysm repair. And let's say you train in a particular place and you go out and you help either start an aortic program or you join an aortic program, but you start carrying out these open thoracoabdominal aortic aneurysm repairs. There are a lot of different ways to manage any of the individual issues involved in these complex operations. And you break it down into various segments of the procedure, and each one of those, there's a number of different ways of managing the situation successfully. So one of the things that I suggest is that they don't be dogmatic, that they think there's just one way to do things. Secondly, is they build a team around them, because even though the surgeon is important, the thing that really makes a difference to the team is the team. Anesthesiologists, the perfusionists, the nurses, the scrub nurses, and even the critical care doctors in the pre and post-operative management of these patients. So establish a way that works for you and your team, that they all get used to, and that the thing that you want to avoid, I believe, is changing what you're doing on every case, thinking that the new shiny whatever might make a difference. And so get your team used to a specific way of managing these situations, so that they have some assurance of what's going to happen next in the procedure, etc. And then, if you want to evolve the process, take it slowly. You know, one change at a time. Keep your team knowledgeable that change is going to be made. If it works for you, fine. If not, go back to what's tried and true, and then evolve the process slowly, so that you're not having a different technique and conduction of the procedure different for each individual case, because it can be very confusing to your team. The other thing is, because the team's so important, don't have a different scrub nurse. If you're going to do 10 cases, don't use 10 different scrub nurses, 10 different anesthesiologists. Build some people around you that are used to these kind of cases, that are not bread and butter everyday sorts of things, but that they develop an experience with you, so that they can work synonymously with what you're trying to do on an individual case, without having to second guess things. That'd be just some basic things to go by.
Right. Thank you very much for breaking that down for us. if we could shift gears a little bit towards perhaps patient-centered questions for patients listening in today. In your experience, what are some common fears people have when told they need to have aortic surgery? And how do you help manage some of these concerns?
Very interesting. When we were first operating on thoracoabdominal aortic aneurysms or arch aneurysms, et cetera, my predecessors and in my early career, the mortality rate, for instance, was extremely high, 30% to 50% in some cases. It's still, in a relative sense, higher than, say, coronary artery bypass surgery or single valve replacement, et cetera. So, quite frankly, one of the things that a lot of patients fear is death. The other two things that really get patients' attention with regards to fear or concern, and particularly in older patients, many older patients would tell you that they would rather pass away than have a stroke, which is going to alter their quality of life in a massive fashion and alter the quality of life for their families, et cetera. And so, particularly in arch surgery, there's a risk of stroke, which is higher than a lot of other operations, which we do as cardiovascular surgeons. So we have to lay their fears of the fact that, well, the chances of them passing away from the surgery is really actually quite small now. It's in the lower single digits as opposed to the 30 to 50% that I mentioned from years ago. And the same thing applies to stroke, but it is a concern for them because if they look into the situation with any thoroughness, they're going to realize that stroke is a lot higher risk than in other the so-called routine cardiac surgeries. In thoracoabdominal aortic aneurysms, there's a third risk that patients are concerned about, and that's paraplegia, a stroke of the spinal cord, where they lose function of their legs. They can lose bladder and bowel control with paraplegia. They can also lose sexual function. So this is one of the things that actually we've devoted a great deal of our time, both with my predecessor, Dr. Stanley Crawford, as well as what I've done over the last several decades, is trying to significantly reduce the incidence of paraplegia because it is such a devastating complication for patients. It's a form of stroke for patients and their families and what they go through for the rest of their lives. In the really extensive aneurysms under Dr. Crawford's work, the risk of having a problem with the spinal cord was as high as 30%, and now we've got it down to around 3 or 4%, which is still, in my view, still way too high, but remarkable progress has been made, and it's one of the reasons that patients and physicians who are referring patients to have that kind of surgery seek out institutions that have a program which allows the risk of paraplegia to be as low as it can be in this day and age. And we're still working on that, by the way. Even though I've been doing this for a long time, we're still evolving, tweaking some of the things that we do to try to reduce the risk of these devastating complications. So the three things that patients are worried about are death, stroke, and paraplegia. And you have to allay their fears.
Understood. And of course, thank you for you and your team showing how important it is to continue trying to find ways to combat these problems and for the work you continue to do. We have a lot of medical students on the line. We have a lot of patients and a lot of caregivers as well who might be new to aortic disease. We were wondering, well, what's something you wish more people knew about aortic disease and its treatment?
There's, it's interesting and not necessarily a pleasant thing, but there's a lot of information in the lay press, the lay information pipelines about such things as cancer, lung cancer, breast cancer, prostate cancer, stroke, cardiac disease, etc. Aortic pathology in comparison is somewhat, actually significantly less common. Many patients who have a study, for instance. They have study looking at their gallbladder or a lung problem, and they get a CT scan or an ultrasound, and they hear that they have an aortic problem, is sometimes they will actually say, what's an aorta? There's just not a lot of information out there. So if we had one wish, that there would be more information distributed on that. The other thing is we still have a problem with hypertension in our country, and it, along with age and some congenital issues, have a problem in our country still with the aortic dissection. And you have to have a somewhat of a compassion for emergency room doctors who have to see literally hundreds and hundreds of chest pains before they actually identify a patient who has aortic dissection. And so there have been efforts by the Marfan Foundation, by the John Ritter Foundation, et cetera, to distribute information to emergency room physicians, nurses, et cetera, to have an awareness of aortic dissection so that it can be diagnosed and treated early, because acute type aortic dissection is still a surgical emergency. And if it's not recognized and not treated immediately, it can, the risk of the patient passing away is just incredibly higher than if it's managed quickly and in a skillful fashion. So, well, it's important, I guess, for people just to make themselves aware that there is such a thing as aortic pathology. If they have an individual in their family, a brother, a cousin, an uncle, et cetera, so that a direct descendant of their family, if they have an aortic problem, whether it be a congenital issue or a problem that arises from hypertension, et cetera, that they be aware of that. There's some more. One of the most common congenital cardiac pathology is bicuspid aortic valve, and with bicuspid aortic valve, there's an incidence of aneurysm of the proximal aorta. And so to be aware of these things, just in the general population, is important. For instance, if you have a bicuspid valve in your family, your near relatives should have an echocardiogram to see if you as well have that. It actually occurs in 1 in several hundred patients, and it's not always associated with aneurysm, but awareness is really what makes a difference, both in the emergency room and in our just general knowledge of medicine and medical care, just among all of us.
Absolutely, and we thank you for helping support our aortic diseases awareness campaign this month of September, and trying to get more people to educate themselves and think aorta when these conditions do arise.
So what makes a difference is what y'all are doing here with this month and this information distribution, going to many people who might otherwise not be aware of these things, and hopefully save a lot of lives as a consequence.
Thank you, sir. We are approaching the end of the interview, and we would love to ask you questions all day, but we do want to be respectful of your time. I was wondering, do you have any closing remarks for our students and young trainees in the audience?
Yeah, the learn as much as you can. There's a tsunami of information out there, a lot more information than we had to deal with when we're students. So the basic recommendation we have there is to learn hard and to work hard. And in my own career, I think applies to people still today, because in their lives, opportunities will arise in whatever career path that they choose. But the important thing is to be prepared yourself to take advantage of those opportunities, to take advantage in a good way, to have the knowledge and the skills that will prepare you to, when those opportunities arise, that you'll be able to make the most of them in any career path that you choose, particularly in medicine and surgery, but could it also be applied to other things?
Thank you so much, Dr. Coselli, and on behalf of the entire TSMA community, our student viewers, our patient audience, thank you for taking your morning and sharing your wisdom with us. It was an honor to have you on.
It's an honor to have been with you and you're to be congratulated tremendously for what you're doing. It's really good work and it's important.
Thank you so much. And thank you everyone for joining live. This recording will be shared on Twitter and on social media, so please look out for the link. Dr. Coselli, thank you, and we hope you all have a wonderful rest of your Sunday.
Thank you. You as well.
Take care.